As Stefan Locarnini already mentioned, there's a lot going on. Hepatitis C is largely a done deal, at least where treatment is regarded. There's still a lot of work to do in the public health sector. But for hepatitis B, we have a long way to go to achieve cure. Hepatitis C is a curable disease. Hepatitis B is a treatable disease. And it's good to see that many companies are actually reinvesting their research dollars in the field of hepatitis B, particularly for someone like myself who has done most of the research in hepatitis B over the last decades. These are my disclosures. And definitely the hepatitis B treatment paradigm will be changing in the future. Currently, we treat most of our patients with nucleoside analogs, which has to be given indefinitely for the vast majority. There's very poor off-treatment response. The good thing about these drugs is that we have proof now with long-term follow-up that they reduce liver cancer, they reduce liver cirrhosis, and they even reduce liver-related and all-cause mortality. So that's a very good thing to have. The problem is that they cannot cure disease. So we'll move, hopefully, to a paradigm of finite treatment with cure, whatever you want to give the definition. Stefan talked about that extensively. Usually we think of functional cure because it's very difficult to achieve a full cure, getting rid of all of the cccDNA eventually. And most of these companies are investing the research dollars that I just mentioned in achieving this cure. It is different, though, from hepatitis C. For hepatitis C, we had our non-responders, and these patients really didn't have anywhere to go, so they were desperate. In hepatitis B, we do have good treatments, as I mentioned, reducing the solid endpoints like liver cancer, as I mentioned. So it will be much more difficult for us sometimes to recruit patients into new studies for hepatitis B, and we have to have very good treatment with which is very well tolerable and with limited toxicity. We still have PEG interferon, which is a finite treatment and is effective in a subgroup of patients, but it has a lot of toxicity and is therefore not given a lot, particularly not in North America. So why is finite treatment a goal for hepatitis B? I think younger patients might find it very difficult to accept lifelong therapy. There's women who want to become pregnant, where we sometimes may have to discontinue treatment, although some of the nukes are relatively safe during pregnancy. There's definitely long-term adherence issues, particularly if patients don't have a lot of complaints. They tend not to take their drugs very well, at least some of them, and there's cost savings involved. Because if you have to give a drug for 30 or 40 years, it will be a lot of money. And a lot of patients, actually particularly young patients, are sometimes reluctant to start on treatment. And there's also patients who have been on treatment for quite a while and say, "Doctor, why can't I stop this treatment? Do you have anything on your shelf which could help me?" So if you look at the life cycle of hepatitis B and the different treatment targets, there's a lot of companies working on different targets. And I'll go through them, and I've kind of divided them by drugs which mainly work as a virological agent or drugs which tackle the immune system. So let's start with the virology part of this. I think a big discovery here is the discovery of the NTCP receptor, which really opened the door for high throughput screening and is an important tool also for designing new drugs for hepatitis B. It's a receptor also involved in bile acid transport. So this receptor was discovered in Beijing, and the other side of the world, in Heidelberg in Germany, Stefan Urban and his group almost initially independently found a compound now called Mercledex B, which is a chemically synthesized lipopeptide derived from the envelope of the virus, which is able to block viral entry into the hepatocyte. So that drug was developed, and a study was recently done, a phase 2 study in Russia, where particularly e-antigen negative patients were treated with this particular compound, given subcutaneously in different doses during 12 to 24 weeks. And as you can see in the bottom of this slide, there was HBV DNA decline. It was more than 1 log in the majority of patients with the highest dose. It was not astonishingly high, but it was there. There was ALT normalization in 55% of the patients, for what it's worth, but there was no significant effect on S antigen levels. And S antigen levels is still what we, at least as clinicians, regard as the holy grail to become S antigen negative and anti-S positive. And with different drugs, we might have a different value of S antigen decrease and S antigen loss. It might well be that with newer agents, patients might become S antigen negative, but very quickly might have an S antigen seroreversion after you would discontinue these treatments. So let's move on to the control of elimination of cccDNA, which could be done through different mechanisms, which is a very tough nut to crack because it's hidden there in the nucleus of the cell, and it's difficult to get rid of. Ulla Protzner from Munich published this paper, which I think is a pivotal paper, in which non-cytotoxic degradation of cccDNA was related to the lymphotoxin beta receptor through upregulation of ApoB3B and for interferon alpha through upregulation of ApoB3A, and then you would get deamination of cccDNA and subsequently degradation. There's other, let's say, treatments designed to tackle the cccDNA, and there's zinc finger nucleases or sulfonamide compounds, which can give direct destruction of cccDNA, inhibit recombinant DNA conversion to cccDNA, or take care of epigenetic control. These are all in very early development and have not been tested in patients, and it's very difficult. It's likely that many of these compounds will have side effects, and several of them will never even make it to the clinic. Another approach is RNA interference that Stefan talked extensively about. The hepatitis B virus is susceptible to RNA interference because it replicates via an RNA intermediate. It is now possible to deliver these compounds through nanoparticles or loop nucleic acids in a better way. It was always difficult to get these compounds to the place where you want them to be. And they can really knock down the production of HBV genes and thereby significantly decrease the number of infectious particles and the antigens. And you can really design these drugs in such a way that you would get S or E antigen decrease. And the hope is that this decrease of these antigen will permit to mount an immune response which will eventually take care of the virus. It's very questionable if that would not happen, whether E losses or S losses with these particular drugs will be sustainable after discontinuation. The RSC 520 drug is the one furthest in development. There are several companies working on these type of compounds. Stefan just showed some data on chimps, and actually next week in AASLD there will be data presented which are already in the public domain in the abstract of the late breakers, where in humans with a single IV dose of 1 to 4 mg per kilogram together with entecavir, they found a mean maximum HBs antigen decline of 1.1 log with a maximum of around 2 logs in E positive, and as it was mentioned before, a much lower decline in E antigen negative patients. These were patients all either pre-treated with entecavir or subsequently at the same time treated with entecavir, and particularly those patients who had been pre-treated with entecavir had a less good response, and 23% of the patients reported mild to moderate side effects. Another compound, or a class of compounds which is being developed by several companies, is capsid inhibitors, which really disrupt the HBV life cycle and thereby destabilizing the nucleocapsid and blocking RNA packaging in such a way that they would produce empty capsids lacking any genetic information. So that could potentially inhibit viral assembly, HBV genome replication, CCC, DNA replenishment, and hepatic reinfection cycles. And a company called Novira is pretty far along with this particular compound called NVR3778, again being presented at the late breakers next week, where in humans, in healthy volunteers, there were no adverse effects, and in a phase 1b study, where patients were treated with 1 to 600 milligrams, a mean HBV DNA decline of 1.7 log was found in their highest dose group after roughly 1 month of treatment. There was one patient with a serious rash, and definitely these drugs are not sufficient by themselves to get functional cure. So this drug, as well as many of the other drugs, are being tested together with other antiviral compounds, and in this case they will move on with testing higher doses of NVR3778, as well as combination treatment with PEG interferon. Then there is tenofovir, which is the compound which is pretty far in development, or actually very far in development now from Gilead. It's a kind of super tenofovir. It has an improved stability in the plasma, and therefore higher drug levels in the hepatocyte. So it's in fact it's tenofovir which can deliver it at a much lower dose with a higher efficacy. Phase 3 study is almost finalized for this particular compound, which has also been given in HIV. It's probably less toxic, they think at least, less nephrotoxic, and there's less bone toxicity potentially than with tenofovir, albeit also with tenofovir we rarely see severe problems. It is not a drug expected at all to give any kind of functional cure. It's just another nucleoside analog which is stronger than the previous ones, or at least potentially less toxic, and we'll see the results very quickly. So these are kind of the virus targeting compounds that I haven't touched upon, the HBs antigen release inhibitors. And it's nice to see that all of these compounds are being developed, and even nicer to see that some of these compounds really teach us more on the molecular virology of the hepatitis B, as Stefan Loccarnini just mentioned, the difference between the E positives and the E negatives. So let's move on to the immunology part of all of this, because I do think that just with an antiviral or with virologic agent, it'd be very difficult to get true immune control, functional cure over the virus. So there's PEG interferon lambda, first of all, which Henry studied. It's still not, I think, appeared in the full paper, but I hope it will come out, because I do think these are important data. A drug developed by BMS initially for hepatitis C, where it was completely bypassed by all of the very potent DAAs. Then tried in hepatitis B, where I don't think really a good dose-finding study was ever done. But anyway, this compound was given at 180 micrograms and compared to PEG interferon alpha. And interestingly, at the end of treatment, there tended to be like an equal response rate if you would look at E seroconversion. But then again, there were more relapses post-treatment in the PEG interferon lambda group than in the PEG interferon alpha group, where actually there was some kind of immunological carryover effect and harboring additional response, which was not at all the case in PEG interferon lambda, and I don't think that a lot of is done with this particular compound at the moment for hepatitis B, but it's still something to pursue further in the future, I think. There's toll-like receptors. There's again several companies working on this. The one further ahead is the TLR7 agonist, developed by Gilead, and TLR7 is a pattern recognition receptor in endolysosomal compartment of plasmacytodendritic cells and B cells, and it induces an antiviral response via innate immune activation. So it has been tested in animal models, in chimpanzees, by Dr. Lanford as well, who still has these chimpanzees and uses them to test these kind of antiviral compounds. There was a clear decline in HBV DNA and S antigen in these animals. And it was also tested initially in phase 1 in healthy controls, as well as later on in patients with hepatitis B. And in those patients, as you see here on the right side, there was definitely an activation of interference-stimulating genes, but there was no clinically significant changes in S antigen and HBV DNA. It could be the case that it was dosed too low. The tricky thing with all of these immune modulatory compounds is that if you don't give enough, nothing happens, and if you give too much, you might run into severe toxicity. So you want to tickle the immune system somewhat to tip the balance into immune control, but if you overstimulate the immune system, you can get in big trouble and get huge flares and apoptotic livers, and we don't want to call the liver transplant surgeon for those patients, so that is a bit of a problem. Anyway, in woodchucks, it was also tested where, again, a profound decline in HBV DNA as well as S antigen was found. And also there was much less HCC. These animals tend to develop liver cancer fairly quickly, and that was hugely reduced with this TLR7 compound. It is being tested now in the clinic, I think in phase 2, in combination with nucleoside analogs. Then we move on to the area of therapeutic vaccination. We've been using Alex Forster just told us that, the vaccines are hugely effective to prevent disease, but the story of therapeutic vaccination hepatitis B has been rather disappointing, I must say, over the last decades, because we've been working on that for quite a while. And it is just very difficult to get an immune stimulant in these patients who've been exposed to viral antigens for decades and all of a sudden stimulate the immune system with a vaccine. Tarmogen is again a compound from Gilead, and it's a genetically modified yeast that you can pack with epitope as you like to design a therapeutic vaccine for a specific disease. And that's currently being assessed in patients together with antiviral treatment with nucleoside analogs. It contains the X, the S, and the core antigen of the virus. DNA vaccination has been done with, again, not a lot of success. A study from roughly 10 years ago appeared to be successful with a vaccine containing the small and middle region of the S of the envelope of the virus, which was safe and did elicit an immune response. However, a recent study done by the group of Stanislas Paul in Paris, where he treated patients with the vaccine, patients who were on antiviral treatment for a longer period of time, and he randomized patients into those receiving a DNA-based vaccine and those who did not. And then a couple of months after those treatments, he stopped treatment in both groups, and the ones who did receive a vaccine didn't do any better whatsoever than those who were just on nukes and where treatment was discontinued. An interesting option is to revitalize T cells, and this is done through checkpoint inhibitors. So usually there's an inability to eliminate the virus in chronic hepatitis B that has been attributed to these programmed death-1 or its ligand PDL1 on viral antigen-specific T cells and antigen-presenting cells. And if you block the interaction between PD-1 and PDL1, you can, in fact, reverse exhausted T cells and get them into cytokine production and let them become reactivated. These type of drugs have been used extensively in the field of oncology. It's successful in melanoma treatment, been used in HIV. And one of the first studies done in hepatitis B is this one from Michael Roggendorf out of Essen in Germany, where he treated woodchucks with a combination of different compounds, actually. They were all on entecavir, And they were either on entecavir alone or an entecavir together with a plasmid vaccination, or DNA vaccination, sorry, or together with an anti-PD-L1 antibody. So some of these animals had 3 drugs, some had 2, and some had just 1. And in the combination regimen, he did see enhanced HBV-specific T-cell activation with a more robust and even more, interestingly, I would say, a more sustained suppression of HBV DNA, as you see here, actually in the, where's the pointer? In the blue line. So the blue line are the animals who received all 3, including the PD-L1 blocking agent. And there you tend to see a more sustained low levels of both Wuchok, so the WHV DNA, so the HBV DNA, as well as the S antigen levels tend to go down, whereas in all of the other animals it went up after treatment was discontinued. So this is a kind of proof of principle study that indeed with combination of immune modulatory therapy with antiviral agents, we might come very far achieving that holy grail of functional cure in hepatitis B. The last compound that I would like to touch upon is this, what they call STING agonist, and STING stands for stimulator of interferon genes. STING is activated by various stimuli such as foreign DNA, and in turn it produces antiviral type 1 interference and will have a role in the innate antiviral immune response. So there are several compounds, but one of them is this compound called DMX-AA, which is a STING agonist, which might elicit a cytokine response, mainly by interferon beta, which has resulted in HBV DNA decline. All very early in development. Most of these drugs that I've mentioned will not be close to the clinic at all, even not in the coming years. Some of them might be, but most of these drugs have a long way to go. So there are coming new drugs on the shelf every week. They're disappearing drugs from the shelf every week. It's actually a thrilling time to be an investigator in hepatitis B, and the challenge is really to combine these drugs in such a way that they will be curative. And there's many drugs to be combined. There's always a risk of toxicity if you combine drugs, but that's really the way to go forward. So in conclusion, Mr. Chairman, ladies and gentlemen, I do think that nukes are around. They're very effective, safe, and they might be pretty difficult to replace. And we do have more troubles recruiting patients for new hepatitis B compounds than we had for hepatitis C compounds, because again, many people are on stable drugs where the virus is inhibited and the disease is in remission, and some of them just don't want their life uprooted with new compounds at all. Yet I do think it's very important to develop drugs which are finite and which will lead to S antigen seroconversion. So our next challenge in hepatitis B is not HBV DNA suppression, but is immune control and functional cure over hepatitis B, whatever you want to define that, however you want to define that. There are new viral agents in development. HBV entry inhibitors, small interfering RNA, capsid inhibitors are all promising, but in early development. Direct cccDNA inhibition may be needed, but it's very difficult to reach. You need gene therapy or other compounds which will be difficult to deliver or might be toxic. And on the immune modification side, we have interesting compounds like TLR agonists, therapeutic vaccinations, checkpoint inhibitors which are in development, and combination therapy is most likely needed. Thank you very much.